First of all, welcome to the session on applications of AI in healthcare imaging and revenue management. So for those of you who know, in healthcare, the decisions that are made by physicians and healthcare workers can be life-altering, if not life or death situations for a patient, and there is no room for errors. Beyond patient care, healthcare professionals are burdened with mountains of administrative work, from the tracking of medical records, filing of insurance claims, and complex billing processes. The operations behind the healthcare system is immense and, as a result, expensive. During this panel discussion, our speakers, Nguyen, Varun, Ganapathi, and Wardah, Inam, will be exploring the status of the adoption of AI in radiology, how it can be used to improve the efficiencies in administrative healthcare costs, and how AI can improve dentistry and make it more patient-centric. Our first speaker is Nguyen. Glory is a vice president of corporate strategy at Radiology Partners, the largest physician-owned radiology practice in the world. There, Glory focuses on advancing AI adoption to transform radiology standards of care, and previously she was a senior manager at Bain & Company, leading healthcare strategy and acquisition due diligence projects. She holds a bachelor's degree in economics and bachelor's in management science from MIT, and an MBA with a concentration in marketing from Wharton. Welcome, Glory.
Thanks, Stacy. When people hear where I work and what I do, the first question I always get is, Glory, why isn't AI reading my x-rays? Aren't radiologists going to be replaced by AI? And this is a pretty common question that I get. Who you see on the page here is Geoffrey Hinton. He's also known as the godfather in AI. In 2016, he made the prediction that, you know what, we should just stop training radiologists now. They'll be irrelevant in 5 years. AI will be better. 7 years later, we have the worst shortage of radiologists in the history of modern medicine, and we don't need fewer radiologists. We, in fact, need more. Well, it's fair to ask, maybe he was just wrong about the time horizon. Is the end state right? Is the end state AI will replace radiologists? And RP has worked with AI since 2015. To date, we have the largest clinical deployment of AI in the world. We have run dozens of AI models on hundreds of millions of exams, and the majority of our 3,600 radiologists work with AI in their day-to-day clinical practice. And we can definitively tell you, no, RAD and AI is better than either alone. We have, like I said, the largest clinical deployment of AI, and we've done it at scale. And we have proven time and time again with multiple different models that the AI does not perform better than a radiologist plus AI. The AI might be 95% accurate, the radiologist may be 95% accurate, but they're different types of accuracies, and then together they get to you 99.99%. Okay, well, if radiologist plus AI is better, why isn't AI everywhere? That doesn't make any sense. AI makes you better. Every radiologist should be using it. Well, in order to answer this question, you have to realize that AI is a clinical tool, not just a tech tool. And just like every other clinical tool, it has the same barriers to entry. First, physicians have to know when and how to use AI or not. It can't be more difficult for them to use AI in their day-to-day practice. Someone's got to pay. Let's check these one by one. One, physicians need to know how and when to use it or not. Imagine that AI is perfect. It's never going to be. But if it were perfect, it would be easy to use, right? It's always right. You can always listen to it. But AI is imperfect. The data it was trained on will inevitably be different than the data it encounters in the field. And why? In radiology, the machines it got acquired on may be different. The protocols that were used for that acquisition may be different. The quality of those exams run by the technician may be different. The patient population is likely going to be different, and absolutely the disease prevalence will be different. And that's actually the most important thing. And so how the AI performs when it encounters these imperfections or differences matter. But what matters more is the physician's comfort in understanding the data will be different, and how does the AI perform in these situations. Imagine if you're a cardiologist and you're implanting a heart stent, and the heart stent differs in its performance depending on the building you put it into the patient in. You would be damn sure that you wouldn't put that heart stent in until you knew exactly how it performed in that building. Not how it did on average, but how it performs in your location. This is just like that. So what did we at RP do? Every single model that we run, we have to validate first, and a mass validation across hundreds of millions of our exams. We make sure to understand where the models are strong, where the models are weak, and how does a physician use AI effectively. And we create training materials, just like you see here, that allow our physicians to become more comfortable with the AI. This isn't super practical outside of an organization as large as RP. The investment required in order to run the AI, to learn from it, to create training materials, and to roll it out across the practice, the majority of practices, they're not able to do this. The average size radiology practice in the US is about 10 physicians. RP is 3,600. Okay, but pretend that there's education materials out there. Second, physicians have to be able to use it conveniently. You can't make their life harder, right? You can't work harder in order to be better. That's just not going to work. And right now, I get a lot of AI pitches that don't really understand the workflow of the radiologist. It's a really great algorithm in isolation, not really good for practical use. And then third, someone has to pay for it. This is what the industry looks like right now. Everyone is pointing to everybody else on who pays. And again, I get a lot of pitches about, Glory, this makes your radiologist better. Don't you want to buy it? Unfortunately, by making the radiologist better, by enhancing the clinical detection rate, the only one that financially benefits in this situation is the insurance companies. And the insurance companies are super conservative and not going to do anything until they prove at scale that it quote-unquote works and it saves them money. Well, to prove it works at scale, you need to pay for it at scale. To pay for it at scale, you have to show that it works. It's a catch-22 that we haven't quite solved yet. And so the question is, how, in the meantime, do we get this paid for? Who pays for it? And so when AI companies come to radiology partners, that's what I want to hear, and that's the one thing that very few have thought about. So where are we now? Venture capital money is pouring into the space. We have about 500 and change FDA-cleared algorithms for imaging. 3/4 of them are in radiology, and there's an exponential growth in the numbers that are getting FDA approved every year. But you're not seeing the same adoption in the market that you see in clearance. And the reason for that is the physicians have no idea how to use it, the AI companies have not integrated it into their workflow, and nobody's figured out the business case yet, except for RP. So, thanks. And I give it back to Stacy.
Thank you, Glory. Next to present is Dr. Varun Ganapathi. Varun is the co-founder and CTO of AKASA, developing AI systems for healthcare operations. He holds his bachelor's in physics, a master's in computer science, and a PhD in artificial intelligence from Stanford. Prior to AKASA, Ganapathi co-founded computer vision company Numovis, which was acquired by Google, and IDE startup Terminal.com, which was acquired by Udacity. And he has advised several AI and machine learning companies, including self-driving startup Zoox. At AKASA, Dr. Ganapathi focuses on applying AI to streamline healthcare operations, reduce costs, and improve workflows. Varun?
First, thank you all for being here. It's a privilege to talk to such an impressive and accomplished crowd. Hopefully I'll have something interesting to tell you about. So the first thing that I wanted to alert you to is there's this massive problem in America that people don't realize. Like, where, we always talk about how healthcare costs so much. It turns out like a large percentage of that is literally wasted. It's like, every visit costs like $20.50 basically to just do the paperwork and like essentially the transaction cost of getting paid for the work that you do in healthcare. It's $100,000 a year per physician. And it all adds up, including other things, to $265 billion wasted overall, like every year, just in administrative complexity. These are all numbers from 2021, published in a Stanford article that I found. That's a lot of money. I mean, that's 2 or 3 open AIs every year is just wasted, on essentially nothing, right? And so AKASA attempts to solve this problem. Like, our goal is essentially to eliminate this administrative complexity and just essentially completely streamline how healthcare works from an administrative standpoint. So what exactly is this administrative complexity? Well, everyone talks about it. When you dig into it, where's all the money going? And there's maybe a few examples I can give you that you might directly be aware of yourself. If you ever tried to get an MRI, maybe you've become aware of the hell of getting prior authorization, where a doctor essentially has to get approval from the insurance company to get you an MRI. And then what will normally happen is the insurance company will say no, because they don't want you to get an MRI because, well, then they might find something, then they'll have to pay for whatever that is too, right? And so essentially there's a lot of resistance to essentially letting you get your MRI. That's one example. It's called prior authorization. And the rate of prior authorization, which means getting authorization for a procedure or service before it is done, is just going up and up and up, right? That's one example. Another example is all of the work involved with just documenting what was done and sending that to the insurance company so that they pay for it. This itself costs, probably on the order of, I think $50+ billion a year just in that. It's called like medical coding. I could give you a lot of other examples, but there's just a lot of administrative complexity in healthcare, which we believe can be eliminated. The next big problem I want to talk about is medical errors. This is even scarier, perhaps, because at least the first one was just money. This is people dying, right? So 800,000 Americans die or are permanently disabled every year due to misdiagnosed medical conditions. 11% of those events are due to medical errors, and nearly 1 in 4 patients who are admitted to U.S. hospitals will experience harm. Harm meaning some unnecessary damage that occurred unrelated to the actual disease or condition that they went in for. So they came in to get something done, some mistake happens, and then they experience some harm as a result of that. That is a crazy high number, right? That's a lot of error. And so, when we, in the previous presentation, you talked about why are we not using AI in healthcare? It's almost like, when you look at these problems, it makes you wonder, how can we not be using AI in healthcare, right? These are some massive problems that need to be solved, and we should figure out a way to do that. So what we focus on at AKASA is essentially, we've started with the first problem, is we've started with administrative complexity. We think, let's try to help hospitals get paid. Essentially, that's something they're probably very motivated to do, and it's worked out so far. And basically, by doing that, we get access to all of this clinical data, which hopefully will help us do the second part of this, which is how do we actually eliminate medical error. And what's really interesting is that the same technology can help with both problems. So one of the key problems in healthcare is essentially reading all of these clinical records, making sense of them, and then doing something with that, right? Doctors produce reams of progress notes, lab results, imaging notes. Radiologists produce summaries of what they saw. There's also the images themselves, of course. There's tons and tons of data being generated, and all of this administrative complexity really revolves around taking that unstructured human-generated or lab results or that sort of thing generated data and turning it into something structured that can then fit into a workflow that will that will help the hospital or whatever get paid for or whatever it might be. And so what we do at AKASA is we take large foundation models, LLMs, and we train them on the customer's data. And so, Gloria mentioned this point about, does it work on my data? I can train it on someone else's data set. Will it actually apply to the data set I have? And so what we do is we take these foundation models, which have already, essentially you can think of them as like an 18-year-old. They know basics of the world, but they don't know about healthcare. And we take them, we train them on all of this healthcare specific data. And then we go one step further, is for every single system we work with, is we fine tune that LLM on that customer's data so we can make sure that it actually works on their specific problem. And then we use that to solve various problems. Like one example is for prior authorization, we'll automatically answer the questions that the insurance company has. They'll say, why does this patient need an MRI? The system, the AI will say, well, these are the reasons. Here's the clinical documentation to support that. Approve it, And like we actually can see from historical data how often does what we generate result in an approval and actually make sure it gets approved. So that's like one example of a type of thing we do. But the really cool thing to me is the second part, which is like, how can we use this to actually help with medical error? There are so many problems that LLMs could help with. In particular, what if we could have every doctor get a second opinion automatically, like in real time from AI? Like alert them to they're possibly making a mistake. They've prescribed a medication dose that actually conflicts with some other medication that this patient already has. Or there's patients who look like this patient normally have this potential outcome or this future diagnosis that could happen. Maybe a test should be done for that. So what's really amazing about these LLMs, and I think is going to change the future, is that we don't have to train one for every specific problem. In some sense, we can train it for just understanding this domain really well, and then we can leverage that same foundation model to solve multiple problems in healthcare downstream. There are tons of ideas. I think we'll talk about them more when we get to the Q&A section, but I just wanted to tee up, like, these are the two big problems that I think should be solved and we should all be thinking about is how can we use AI to really solve these two big problems in healthcare, because they affect every single one of us. Like, we all are going to have healthcare needs at some point. We're all going to get older. We have parents. So this affects all of us, and so we should think about, like, how can we use AI to help us solve these problems. So that's it. Thank you.
Thank you, Varun. Next to present is Wardah Inam. Imaging plays a huge part in the world of dentistry, and Wardah Inam is the co-founder and CEO of Overjet, a Boston-based startup using FDA-cleared AI to analyze dental x-rays. Since founding Overjet in 2018, Wardah has raised nearly $80 million from investors like General Catalyst to build technology that assists in diagnostics and helps insurers make claims and decisions. Overjet's AI platform reaches 100 million people in the United States through dental practices and health plans. Inam holds a PhD in electrical engineering and computer science from MIT, where she researched energy-efficient technologies for renewable energy. Prior to Overjet, she was lead product manager at Q Bio, developing simulations of human physiology, and Inam has been recognized as one of Boston Globe's tech power players, Incisal Edge's top 32 in dentistry, and Inc.'s Female Founders 100. Welcome, Wardah.
Thank you, Stacy. We've heard today from many speakers on how AI is impacting many different facets of our lives and how we work. The question that I'm really focused on is, can AI completely transform dentistry? The current dental system, or dental care system, has misaligned incentives for both payers and providers. 30% of the cost is spent on administrative cost, which is loss and waste in the system. Patient's disease is treated in silos rather than looking at the complete patient health. And we believe that we can completely change this and make it more patient-centric care, in which the patient is in the front and center of the care that we provide. Using AI, we can make it such that we're providing high-quality diagnosis and providing the recommendations for the right treatments at the right time. We're empowering patients to understand their health and make the best decisions for themselves, and not treat disease in a silo, but be able to analyze all patient data to help impact their overall health. And lastly, decrease costs from the system, the administrative, the manual work that happens, such that the dental staff can do what they do best, that is provide the best patient care. But it isn't that easy. The dental care system is run on archaic infrastructure. Currently, many dental insurance companies are utilizing mainframe computers running COBOL with constant IT freezes and patches on patches being deployed. On the other hand, you have dentists who are using and collecting significant amount of data on each patient. And this data is unstructured. You're talking about radiographs, you're talking about notes that computers can't really analyze. And this is where AI can really help and help us leapfrog the system and in providing the best care possible. Here, Overjet's AI looks at dental x-rays the way humans would or dentists would. But what's really unique here is that we're able to quantify disease, so give capabilities that dentists don't normally have, and then be able to also visualize the disease so that patients can understand their health and make better decisions for themselves. Also, we're able to read notes, and dentist notes are very hard to read generally. But we're able to read the notes as well as possibly take all the information that is in the system, that is not only their dental histories, but also their medical histories, to ensure that the right care is delivered to them, considering their full health, not just their oral health. And how that works is that currently, think of it as a co-pilot for the dentist, helping them provide a more comprehensive diagnosis to the patients, and more importantly, quantifying and visualizing the disease so that the patients are more informed about their oral health, such that they can make better decisions for themselves. And also start to connect the dots between oral health and overall health. Currently, in healthcare, your mouth has been separated from the rest of your body. However, research shows that oral health or overall health is dependent on oral health. Very important conditions such as diabetes or other chronic conditions such with heart disease, etc., are linked to oral conditions such as gum disease. And now, by looking at all the data, we can actually start to not only treat patients' disease as a silo, but look at their whole patient health and start to impact not only their oral health, but also their overall health. And lastly, this is something that Varun mentioned as well, there's significant cost in the system because of manual processes. Not only do you have claims being submitted manually, but also claims being reviewed manually. You have benefits and eligibility checks happening every day for different patients. You have quality audits happening manually. And all these manual processes are not only costly, but they're also error-prone. And with Overjet's AI, you can start to not only analyze this information, but start to automate these processes such that you can make, again, better decisions, but also reduce the cost out of the system such that that cost can be spent on patient care. This does, or especially if you're in healthcare, this does seem utopian, and when we talk about we're making dental care patient-centric, but the awesome thing is that it is already happening. At Overjet, we're working with some of the largest dental insurance companies, as well as some of the largest dental groups. And these companies serve more than 80 million members and thousands of practices that are using Overjet's technology to provide the best care to the patients, such that we can really look at and try to improve not only the oral health, but overall health of these patients. So at Overjet, we're helping make AI more patient-centric, and I think AI can help healthcare be more patient-centric as well, and that is the opportunity in front of us. Thank you.
Thank you, Wardah. Okay, so now we're going to open it up to Q&A, and so if you have a question, be sure to click on your badge for the Slido, and you can submit your question from there. So I'm going to open it up. I'm actually going to direct this question over to Glory. So in an earlier session today, some of the, they had the discussion of whether or not physicians maybe, could use AI in order to kind of help with the prediction of what to do next and next steps when it comes to the patient treatment plan. Do you think that, how do you think physicians would accept AI in that use?
I actually think that many physicians would be open to that. There are cracks in the healthcare system. Physicians don't necessarily speak to one another, and there's always something that gets lost in translation. In radiology, when we create notes, sometimes we forget to say what those notes mean, meaning I found a 3-millimeter nodule in the lower left lung. Okay, well, you would expect that your primary care physician says, oh, lung nodule, probably should get that checked out. But they don't always do that. They say that they think that if the radiologist doesn't explicitly say, go check it out, maybe it doesn't matter. And so if there's a safety net there to catch where there is these gaps in communication, then I actually think that's better. It's not to say that the physicians don't care or that they wouldn't necessarily catch it themselves, but the volume of referrals and notes and just information that goes through the healthcare system, like something's going to slip.
That's great. Wardah or Varun, do you have any comments?
I think what I can add here is one thing that we've always been really focused on is helping dentists and healthcare professionals provide better diagnosis. But I think an important piece of it that gets missed is it's a very important tool for better communication with the patient as well. In the past, you could, the healthcare professional could make a diagnosis and the patient would follow exactly what the professional said. But especially in today's day and age, everybody wants to question. There's Google, there's all these other areas that you can look at to find answers to your problems. And because of that, they do question. So having AI not only as a tool to help professionals actually diagnose, but also as a great tool, as a communication tool for patients so that they can understand what the dentists are saying with visualization. So the nodule that Gloria mentioned, having that visualized so that patient can understand and so that they can even react. And if there are cracks in the system, they can be more proactive about it.
In the space that we work on, I think physicians are open to this, but they're also, one of the issues that we have in AI and overall is like the Clippy problem. Like Clippy was really bad, right? It made all these suggestions, most of them were not good. And maybe most people don't even remember Clippy. I never actually used it, but I heard about it. Today, like there's a similar problem like we face is like there's this thing called queries. Not to get into too many details, but it's basically when someone sends a question to the doctor and says, like, can you improve the clinical documentation, add some information that was missing, right? Doctors basically ignore them. Like, they just don't answer those, or and partly it's because the questions are often sent really late, like maybe like weeks after they've seen the patient, they don't even remember. I think what I'm trying to get at is like we have to solve the UI problem and also convince them that there's not going to be a lot of false positives. Like this has to be, it's almost like I think we need to insert this in a way where almost everything it says is perfectly right, and then, which is very hard to do, and then gradually increase the amount of things that it tells them. And then we also have to figure out how to put it into their workflow in a way that it makes them faster, not slower. Because they already have too much stuff to do, and so they're already burned out. And so we have to figure out a way to make it so that we're reducing their burnout.
I agree with like majority of what you said, except for the last part. Okay. So, yes, false positives suck. They just do. Like doctors, as soon as you see a lot of false positives, you start ignoring something. However, false positives happen more when prevalence of disease is really low, right? It's just Bayesian. Like the lower the chance of disease, the more false positives you're going to have. In that situation, though, is actually where AI can save lives. Because that's also where the physicians is going to miss it the most. And so when I was saying that the physicians have to learn how to use AI, when to use and when not to use, if there are thematic reasons of what types of false positives there are, or ways that you can start segmenting your false positives, and so you can actually learn to work with the AI more, more seamlessly. The fact that there are more false positives doesn't matter. It's which false positives matter and which false positives don't. As soon as the physician figures that out, doesn't matter. And you actually will save more lives that way, because when there's low prevalence of the disease, that's where mistakes happen, and that's where you're going to have a lot of high positives. I can get almost 100% accuracy by saying there's no disease.
Yeah.
Right? Like that's not helpful.
All right, thank you. So we haven't, do you have something to say about, because we do have lots of questions coming up. So.
Yeah, I agree with what you're saying. It's really tricky when, okay, you go to WebMD, and it basically always says, is there a chance you have cancer? Like, for any symptom, okay? And so if we're always like, it could be cancer to the doctor, like that, like, you have to, it's a tricky, you have to basically, yes, there will be false positives, you're right. And in rare conditions, there are obviously, like by definition, there will be false positives. But we have to make it so that they won't, if they learn to ignore it, then it's basically worthless that it's there, right? And so I think the answer to this question actually it's not like a qualitative answer. It might be actually literally an empirical number answer. Like, maybe it's like, when it suggests something, it's right 50% of the time, like that's okay. If it's right 5% of the time, that's not okay. Or maybe it's, when it suggests something, it's like very easy to respond to that and figure out like what to do next. You just, like in all cases, like in my company, I've learned like engineers will ignore false alerts. Like there's this like the boy who cried wolf problem, and basically it's like the thing might as well not exist. So I think that's a tricky problem to solve.
All right, thank you.
We can keep going. Okay, good. I could respond to this, but maybe we keep going.
So I'm going to move on to the next question. Okay, and this is a very popular question, which is, how do you address bias with respect to race, gender in medical data when training models for healthcare?
Me?
Any of you?
Yeah, it's a problem. And it's a big problem because, I don't have my phone on me. Sorry, guys. I'm always the problem. It's a big problem because there's actually not a lot of data. A lot of the data that the AI gets trained on is not trained on minority data. It's mostly trained on male data, white men. And so the models are wrong a lot of the time. And so there's a lot of ways to address this. The first way is to make sure you're augmenting your data. Many go to other countries, other populations, to make sure that their imaging data is complete. The issue there, though, is that other countries see things like tuberculosis, which isn't really common in the US, so it's imperfect as well. And then secondly, honestly, it's how do you think about working with a clinician in order to address those biases? Like the clinician always has biases. Everybody has biases. Some biases are correct. It would be not efficient for a radiologist to look at every single pixel, right? If you suspect your foot hurts, it's probably going to be a fracture. You're probably going to look at where the most common fractures. You're not going to look at every single pixel. But the AI can. And this is an unsolved problem. I mean, personally, more data is better, but also figuring out how to work with clinicians to figure out where your biases are is going to help.
Okay. Thank you. Wardah?
Yeah, I think to what Gloria said, I think we should stop being okay with being data or models being trained on very little data. I think in healthcare it was just accepted that it's hard to get data, so we'll have very little data and we'll get models out which are not trained on the respective populations that the algorithms will be used, et cetera. I think that just needs to stop. And I think for us, that's something that we do take very, very seriously, where we try to train all, and try to segment the data for all different populations, different age groups, different types of diseases and different prevalence of disease as well. And this is, I think, where FDA is getting better and better at, and their expectations from AI companies are increasing. And for us, and our head of machine learning is in the room, when he joined the company, one thing he said was, hey, let's take all the data that we've ever predicted on, let's use everything we've predicted, and let's train with that data as well. And now we're talking about millions of X-rays that are being used to train. Now you can actually segment on different populations. You can segment on different types of diseases. Rather than just being OK with whatever data we have, we can use models like UNet and other models which require very little data to predict on. So I think that I think with AI now, I think it's something that people are getting used to, that the more data, the better. And this is something that we can utilize and utilize on a larger population as well.
Thank you. And then
Sorry. I just want to add this a quick thing. First, I think when we've done our work, one of the problems is everyone assumes humans are always right and not subject to the same biases. Like, you have to ask yourself the question of, like, why do you think that doctors are not having the same biases? Like, they probably are, and that's probably responsible for some of the inequity in outcomes, right? It's, so that's one thing. Second thing, to both of their points, I think we should try to train on data continuously. Like, in healthcare, we're constantly getting data, we make a decision, but usually what happens is you later figure out what went wrong. Like, even if you made an earlier wrong decision, later something happens that makes it apparent what the actual true answer was. We can use that to create a data set that should be relatively unbiased, because if you can pull from enough health systems and so on, you could actually correct for that. Third thing is, I think unsupervised training. This is the big jump with GPT, was that you could train on unlabeled data. So you could use that here as well. Like, you could just train on unlabeled data from all. And maybe you could even specifically oversample certain races or whatever, if you wanted to correct for these biases. And then that could let you reduce the amount of label data you need in order to achieve a certain level of accuracy.
Great, thank you. Okay, so I think we have time for one last question, and this is a big one. How do you make sure of patients' privacy in case of using a model trained on a hospital for transfer learning to a smaller clinic usage?
For us, we take out the HIPAA data and use the X-rays, et cetera, without, or even in the note, try to remove the patient names, et cetera, from it. So that's how we deal with it.
Yeah, for us, two things you can do. One is you can use LLMs to de-identify the data first, and so, or some other mechanism, and so you have de-identified data in the first place. Second, a lot of the concern about transfer is really when the output can contain PII. So, if you're predicting, cancer or not cancer, it's not like there's no name or something that's going to pop out. It's not like ChatGPT where it's typing in some text, right? And so I think it's harder to violate privacy if you constrain what the output format can be in the first place.
Okay, thank you. And then I guess, do we have time for one more question? All right, one last question. Can you give an example, and I think that this one is for Glory. Can you give an example of how an AI radiology startup failed to make their solution convenient for radiologists' workflows?
Oh my God, I can talk all day. Let's go. All right, so the most common one I see that is, where did the results go? Right? Radiologists read their AI on PACS. PACS is an antiquated system that really doesn't want to do anything with any of the results, right? So you got two bad solutions to go around this. One is you create widgets. And a widget basically pops up and says, okay, well, I found something, go into your PACS and look at it. The other solution is to put a DICOM capture, it's just another image, into the series. Okay, well, if the radiologist disagrees with that DICOM capture, now all of a sudden it's part of the medical record, and they're now exposed. Majority of the time, the radiologist is right, but in the very infinitesimal chance that their disagreement was wrong, now they've opened themselves to medical litigation. Guess what? That AI will never be used. Never. Never. So when you think about the workflow of the radiologist, how do you integrate the result? I'm not even talking about use of the AI. Let's put that aside. The simplest question is, what are you doing with the results? Is that part of the medical record or not? How do I look at it? Do I have to pull up a different window? How hard is it for me to engage with the results that came out? And if you can't answer that, then it's a non-starter.
Thank you, Glory. So at this time, I want to thank all of you for coming today. Glory, Varun, Wardah, fantastic job. Thank you so much for sharing your wisdom with us.
How about another hand for all the great speakers up here? Wonderful.